Welcome to the teleconference session of National Board of Examinations. We will have two sessions devoted to nephrology. In the first session, we will discuss about nephrotic syndrome, and in the second session, we will discuss about chronic renal failure. In the first session, we have three experts. To my left, Dr. Shalini Malhotra. She is Assistant Medical Executive at National Board of Examination. And to her left, Dr. Vishakha Kapoor. She is Assistant Controller of Examination at National Board of Examination. And to her left, Dr. Sanjeev Saxena. He is right now Consultant Nephrology at Pushpavati Sanghania Research Institute. He was earlier faculty at All India Institute of Medical Sciences. He is a Fellow of Indian Society of Nephrology and also a Fellow of National Academy of Medical Sciences. I will request Dr. Saxena to tell us about the nephrotic syndrome. To start with, Dr. Saxena, can you tell us what is the history, what is the classical history of nephrotic syndrome, how it presents?
We will take a classical case by example, and it's a 40-year-old male who presented with insidious onset of periorbital swelling, pedal edema, for which he was consulted his local physician. And there, for the first time, he was found to have mild hypertension and he had a bit of pedal edema. So the important point to note in this presentation is that this is an insidious onset swelling involving the face and the feet. This man had no exposure to drugs. There are a lot of drugs which can cause this sort of a swelling. He had no history of joint pains, skin rash, fever, jaundice in the recent past. These have relevance to the presentation this patient had, and we shall discuss this subsequently. He had no past history of tuberculosis, he never had any high risk behavior, and he has no diabetes mellitus as per the history. For these complaints, he was investigated and he was found to have heavy proteinuria. 4+ proteinuria means heavy proteinuria. There were few RBCs in the urine. The urine culture was done by the local physician thinking that this proteinuria and this RBC may be UTI, but that was sterile. And the 24 hours urine examination showed 6 grams of proteinuria, and his creatinine clearance was 90 mils per minute, which means that his renal functions were all right. His blood chemistry showed that his hemoglobin was normal, his burn creatinine was normal, which again corroborates that the renal failure was not present. His serum albumin was low, this is important to note. His cholesterol was high and his fasting blood sugars was normal. It's important to note that despite the patient not giving any history of diabetes, you must test the blood sugar. The complements were normal. His profile was done in view of his age, the edema for any autoimmune diseases. So his ANA was done, that was negative. There are a lot of viruses which can cause proteinuria. So he was tested for hepatitis B, hepatitis C and HIV. All these were found to be negative. Radiology was done, a chest X-ray was done which was normal. A chest X-ray is mandatory in these people because of the fact that there can be hidden tuberculosis, and I'm sure all of you know tuberculosis is a cause of renal amyloidosis. The ultrasound showed normal size kidney. There was mild increase in cortical echogenicity. There was no evidence of chronic liver disease, that is important to rule out as a cause of swelling. There were no lymph node masses and there was no organomegaly. So based on this history, this patient was referred to the nephrologist, and as the history tells you that there is heavy proteinuria, there is low serum albumin and there is high cholesterol. Since he was negative for any secondary causes as far as the workup goes, this patient was subjected to a kidney biopsy, which is a must in adults with nephrotic syndrome, and this is what the kidney biopsy showed. The kidney biopsy showed this is how normal glomerulus looks like. This is the cut section of the glomerulus, one full glomerulus. This is the Bowman space, the white area that you see, and these are the capillary lumina, these patent areas that you see. The green thing and the cells in between is the mesangium and the mesangial matrix, and this is what a normal kidney glomerulus looks like, and therefore it was termed minimal change disease. There were some areas like this area where there seems to be a little bit of accentuated mesangial matrix, and therefore it was reported as minimal change disease with mild mesangial enlargement, and the IF, which means immunofluorescence, was negative in this patient. So this is what a classical patient with nephrotic syndrome will present, and this was minimal change disease.
Can you tell us, Dr. Saxena, how it differs from acute glomerular nephritis?
Yeah, that's what actually I pointed out, that in acute glomerular nephritis, the edema comes in a few days. So the patient is all right yesterday and gets up in the morning and he notices facial puffiness, pedal edema, and generally acute glomerular nephritis is associated with hypertension, and this is generally not mild hypertension. Is not associated with hypoalbuminemia. If proteinuria has been going on for some time, then only you develop hypoalbuminemia. Acute glomerular nephritis, as the name connotes, is abrupt onset renal disease, and so the serum albumin will remain normal, and as a consequence of low protein, the lipids are high. So all this points to fact that there is no acute event. It's been there for some time. Also, it's important to note that this patient whose edema had come over a period of time. It hadn't come in, say, hours, which is what acute glomerular nephritis is. Importantly, the urine examination makes you decide. Acute glomerular nephritis is generally not associated with heavy proteinuria to the degree 4 plus 6 grams, but is actively associated with an active urine sediment, which means there are a lot of RBCs, RBC casts, WBC casts, which means it's an angry looking urine. The kidney is, infiltrated with cells, and these all pass in the urine. The urine is often called the liquid kidney biopsy. So, the urine can tell you that this is not an acute event, it's a smoldering process, and therefore this fits into what is classically called the nephrotic syndrome. Next slide.
So, what you mean basically in a case of a chronic situation, the creatine clearance will be there, it will be normal, but there will be heavy proteinuria.
That's right.
Then why you are insisting that blood sugar should be done in every case?
Yes. Diabetes is a disease, what is called as the tip of the iceberg disease. You pick up 10 patients, but you miss 90. So many patients will for the first time present as heavy proteinuria, but they are having diabetic nephropathy. So never think that the man, because he doesn't give you a history of diabetes, that there is no diabetes. So that is, I think, mandatory in any adult who has heavy proteinuria. You must rule that out. Then tuberculosis must be ruled out because of the simple reason that's the cause of secondary nephrotic syndrome as amyloid, and it has bearing to what you are going to treat the patient with. Next slide. So this is what we discussed, that nephrotic syndrome, as the word means, it's a syndrome. So there has to be a constellation of signs and symptoms. The sign that we are looking for is only edema, and the biochemistry tells you that there is heavy proteinuria, there is hypoalbuminemia. Consequent to the hypoalbuminemia, there is hyperlipidemia. The lipids leak in the urine and there may be lipiduria. There is also a hypercoagulable state, and is generally seen if the proteinuria is more than 3.5 grams per 1.73 meter square body surface area per day. So the proteinuria is divided into 3 classical varieties. Glomerular proteinuria, as we've discussed in this patient, is generally more than 2 grams. The type of protein leaking is generally albumin. It's a heavy proteinuria, and it's a result of perturbed glomerular filtration barrier. Tubular proteinuria never exceeds 2 grams. It's predominantly the low molecular weight proteins which are part of the tubular secretions which leak out, and is a result of failure of tubular reabsorption of low molecular weight plasma proteins. And then the third category, I am sure you are all aware, classical seen in multiple myeloma, which is because there are too much protein in the serum because of the myeloma, and these proteins leak and they exceed the reabsorption capacity of the tubules, and they are therefore leaked in excess in the urine. Proteinuria has interesting pathogenesis from the fact that we used to believe that there are pores in the filtration barrier which become bigger and leak out. Now proteinuria is believed to be a disease of the podocytes, and it is now being termed a podocytopathy, which means there is loss of podocytes and there is the foot process effacement, and this is classically seen in minimal change disease. The filtration barrier basically does two sorts of barriers to the plasma proteins. One is what we know classically, and that is the loss of the electronegative charge. Albumin is an electronegative molecule, and therefore it is repelled by the electronegative charge of the basement membrane. When there is loss of this electronegativity, albumin leaks out, and therefore the charge selectivity goes. This is located in the proximal portion of the barrier compared to the size selectivity, which is in the deeper portion, and the slit membrane controls this, and bigger proteins like ferritin and transferrin can then leak out. And this is the basis of classifying proteinuria into selective proteinuria and a non-selective proteinuria. Selective proteinuria is when there is only loss of the electronegativity, the pore size remains alright, and therefore only albumin leaks out, and therefore most of the protein that is found in the urine is albumin. No other proteins are, very little of the other proteins are found out. Whereas when there is a destruction of the deeper layers of the basement membrane, the pore size becomes big and you leak out transferrin, ferritin, immunoglobulins, a whole lot of proteins. And this is what is generally seen in a nephrotic syndrome of the adults, and this is non-selective proteinuria. Selective proteinuria is generally seen only with minimal change disease. This is what it must be remembered. There are several genes which have been implicated recently, and several chromosomal regions with proteinuria, and it is believed that probably there may be an underlying genetic defect. There are a lot of viruses which are associated. We've talked about hepatitis B, hepatitis C, HIV, parvovirus, B19, SV40. All these are believed to injure the podocyte and result in leakage of proteinuria. What are the diseases that cause proteinuria or nephrotic syndrome? And this can be classified because there is a difference between children and adults. In children, predominant cause of nephrotic syndrome is minimal change glomulopathy, whereas in adults, membranous glomerulonephritis and focal segmental glomulosclerosis would constitute the bulk of the diseases resulting in nephrotic syndrome. So it's important to know what is the age of the patient while you are discussing a patient with heavy proteinuria.
Dr. Saxena, I have a question. Now that we have come to the age group part of it,
Yes.
Do the parameters that we define the nephrotic syndrome, would they vary in an adult and a pediatric age group, or they remain constant?
Yeah.
And the second thing, the pathogenesis, is there a gross difference in an adult and a pediatric group?
Well, yes. You know, the difference is in the what we call in the pathogenesis, the type of lesion that you get. Bulk of the nephrotic syndrome in children are minimal change disease, and therefore you just lose the charge selectivity. So the pathogenesis is probably mild, and that is why these are children who respond very well to steroids, compared to adults where not just the charge selectivity but the damage is also to the pore size, and therefore there is heavy proteinuria, and therefore the response to therapy is not really as good as you would see in children. Next slide. Besides the idiopathic causes which I listed in the previous slide, there are a whole lot of secondary causes, but I think you must only know the major ones and you should never miss them. One are the viruses, the hepatitis B and the HIV. Then you must remember that the membranous glomulopathy is associated with some cancers, and therefore you must rule out solid cancers in patients. In adults, you also have systemic lupus presenting as nephrotic syndrome, and then since we are talking to physicians, it's important for them to realize that a lot of drugs that they do write for various conditions like rheumatoid arthritis, for osteoarthritis, for blood pressure, for hepatitis B or C treatment like interferon, captopril, NSAIDs, all these can cause secondary nephrotic syndrome. So it's important to know what are the drugs that generally cause nephrotic syndrome. Now, should you biopsy all patients? Well, the answer to that is, in children, you don't need to biopsy, because as we've seen, bulk of the nephrotic syndrome is minimal change disease, and once we come to the disease, we'll find out that without biopsy, you can treat them very well. So it's not essential in children who are between 2 and 14 years of age and who have developed nephrotic syndrome. Apart from that, it's very essential, because you will be surprised many times that you are thinking that the patient has minimal change, but you biopsy and you find amyloidosis. So then you don't need to immunosuppress the patient. You'll be surprised that we have picked up multiple myeloma on a kidney biopsy. There was no clinical suggestion. So it's important to biopsy not only for the cause of the nephrotic syndrome, the type of histology, but also whether there is chronicity. If there is chronicity, you may not like to immunosuppress these patients much. Also, the histology tells you what is the long-term outlook of this man, as we will discuss subsequently. So, if at the presentation the age of the patient is less than 1 year or more than 15 years, you must biopsy these patients. Slide, please. The persistent, if the urine shows persistent microscopic or gross hematuria, or if there are low complements in the serum, if there is sustained high blood pressure, if there is renal failure which is not attributable to, say, loss of fluid in the third space, you must biopsy. Or a secondary cause like SLE or amyloid is being suspected, you must biopsy. In several situations, like in children, you would start treatment empirically, and then if there is no initial response to steroids for 4 weeks, it is best to biopsy and see what the histology is like. Also, there are other drugs which are being used for treating nephrotic syndrome besides steroids, and these drugs may be nephrotoxic. So it's best to biopsy this patient before, say, starting them on cyclosporine. Also, if the patient is frequently relapsing or is steroid dependent, then it's worth biopsying to find out if the histology is non-minimal. Then we come to this question which is often asked. A man consumes, say, about 1 gram per kilo of protein every day. So he is consuming 80 grams or 70 grams of protein. If he loses out 4 or 6 grams, where is the problem? The problem is that there is an intense need to reduce proteinuria. And the reason is that heavy proteinuria is associated with faster decline in the glomerular filtration rate. And the corollary is that, and this is well documented in a lot of studies, that if you reduce proteinuria, even though you may not induce complete remission, with reduction in proteinuria, there is a slower decline in the glomerular filtration rate. So what you are trying to preserve is the GFR by treating proteinuria, which means you are preventing renal failure from setting in. And this has been worked out that if you reduce 1 gram per day of proteinuria, the fall in GFR is slowed by 1 ml per minute per year. And this is substantial in terms of GFR. And this slide just reiterates what I have just said, that those who respond well to steroids seldom go into renal failure, whereas those who show no response, majority of them would go into renal failure. So one of the criteria of poor prognosis is response to therapy that you have given to the patient. Now we come to the first set, and this is what the pediatricians would see more often. This is minimal change disease. We've discussed a bit about the pathogenesis of this, and majority of the nephrotic syndrome, more than 75% of nephrotics in children would be minimal change disease. The disease is characterized by heavy proteinuria. However, heartening to note that the renal prognosis is excellent. These children seldom go into renal failure, and the death in these children is often related to infection, a thromboembolic event, cardiovascular event, or an acute renal failure setting. they are so hypoalbuminemic that all their body fluid is in the third compartment in the form of edema. They have gross ascites and they are hypovolemic, and that causes acute renal failure. Then what is the problem with this disease if the renal prognosis is excellent? The problem is relapses. Relapses are a major problem with minimal change disease. So how do you go about treating if you've diagnosed? I've shown you the slide of minimal change in the first presentation, and the International Society recommends that you treat these children to begin with 60 milligrams per meter square body surface area per day of prednisolone for 4 weeks, followed by 40 milligram per meter square alternate day, another 4 weeks. More than 93% of these children will form the primary responders. That means that with the first therapy, most of them would show complete remission or nil proteinuria. However, 10 months later, if you follow these children, about 38% would persist to have nil proteinuria. So that's about all. So about 40% of them of minimal change would never have any other problem. But what is important is that about a fifth of them would be what are called infrequent relapses, which means 2 or less relapses in 6 months period, or frequent relapses, which means more than 2 relapses. However, in adults, the response to therapy and the type of therapy that we give is generally different. In adults, we give them prednisolone in the dose of 1 milligram per kilo per day or 2 milligram per kilo every other day, and this has to be over a prolonged period of time. So they have to take it for 16 to 20 weeks, and yet despite a long high dose steroid treatment, only a maximum of about a third of them would show complete remission. So it's a tougher disease. Despite the histology showing minimal change disease, they do not respond as beautifully as children do. So important message is that remissions require longer therapy compared to children. You have to weigh against the side effect of steroids over a prolonged period, and therefore you have to be carefully watch the steroid side effects while you are treating adults with nephrotic syndrome. There is a study which showed that if you use pulse methylprednisolone, the remissions may be quicker, and patients who are not responsive to steroids in the first go may turn into responders with oral steroid. So that's an important study to note.
Dr. Saxena, how long the duration of the steroids has been known to be given safely in children and adults?
Well, in children, the biggest problem is that you can lead to growth retardation. So that's a major worry for the pediatricians. So generally, one would not like to exceed, say, 3 months of therapy. In adults, we take more liberty. You can give them for 6 months. But in adults, the other side effects like the avascular necrosis of the neck of the femur, worsening of hypertension, development of diabetes, all these are issues in the adults. So although there may be growth retardation in children, the adults are no different, I would say. So you got to be cautious. That's the main. But as you know, as I've pointed out, our goal is also to reduce proteinuria, because you are preventing, it's a preventable cause of renal failure. So if there is steroid toxicity developing, and if the side effects are unmanageable, if the 3 months of steroids don't give you any response, then what do? Then you have the second line of immunosuppressives in the form of cyclophosphamide, which is used in the dose of 2 milligram per kilo per day, or you can substitute with chlorambucil, 0.2 milligram per kg per day, for those who are not showing any response to about 8 to 12 weeks of steroids, or those who are frequent relapses, they should be given. In children, you should not exceed 3 months of the immunosuppressive therapy with cyclophosphamide and chlorambucil. Here I may also add that these don't work in isolation. So you have to combine them with steroids. They are not drugs which are going to induce remission. These are drugs which are going to maintain remission. So it should be used in people who don't maintain remission. So if you induce remission, you taper steroids, they have a relapse, that is where you got to use. Or you remove these steroids and within a week or 10 days or 2 weeks the relapse happens. This is where these drugs have to be used. The slide please. Pulse cyclophosphamide has been shown at the All India Institute to be better in children versus daily dose of cyclophosphamide as far as the side effect profile in minimal change disease goes. If you add the cytotoxic therapy to the steroid therapy, for those who do not have remission, about a third of them will have further remissions. So you add to the 40% in children, another 30% who will have now sustained remission. So you can use azathioprine in place of cyclophosphamide just as well.
Excuse me, sir. I have
Yes.
a question. If a child or a patient with HIV develops nephrotic syndrome, then can we give these drugs cannot be given?
Well, it's a very important question you raised. You know, what you are asking me is if there is a secondary cause of nephrotic syndrome, is this the regime? Well, I must make it very clear that this is for idiopathic nephrotic syndrome.
Okay.
All your patients with secondary nephrotic syndrome will respond to the therapy of the primary disease. So if you give them heart, the antiretroviral therapy, the patients who have proteinuria secondary to HIV will have remission. They will not have remission with steroids. That's important to remember. Likewise, if you have hepatitis B and nephrotic syndrome, you got to treat hepatitis B, not nephrotic syndrome.
Right.
The next alternative for patients is cyclosporine, and this is a new immunosuppressive agent on the block, and this is generally used in the dose of 5 milligrams per kilo per day. It's for people or children who are steroid dependent or who are showing significant steroid side effects and who are not willing for cytotoxic therapy, because cytotoxic therapy, as you would be aware of, is associated with sterility. So there will be a lot of young girls, young boys who would not be accepting your therapy because there is a fear that in adulthood they will be sterile. So because if they are not willing for toxicity of the cytotoxic drugs, the best is to start cyclosporine. This is given in 5 milligram per kilo per day. It's given for a period of a year after remission with steroids. Again, important to remember, it doesn't work alone. You have to give it with steroids. The only problem here, you have to taper cyclosporine very slowly. So you have to taper by 25% of the dose every 2 months, which means 1 milligram every 2 months, and maintain the patient on the minimal effective dose. So you will reach a dose below which there may be still a relapse. The bigger problem with cyclosporine is that it induces remission, but relapses are fairly frequent after stopping the drug. Cyclosporine is not without side effects. It causes hypertrichosis, which may not be acceptable to young girls. It causes a lot of gingival hyperplasia. It has its own nephrotoxicity. It's associated with hypertension. But in a country like India, most important is it's a very costly drug compared to cytotoxic therapy, which is very cheap, available, easily affordable, and except for the total leukocyte count, it doesn't require much monitoring compared to cyclosporine. So if you don't give cytotoxics, the next alternative for you is cyclosporine. Before anything else, we must know what is steroid resistant nephrotic syndrome. And this is absence of remission despite 4 weeks of daily prednisolone 2 milligram per kg per day in children. So in children, you tend to define resistance pretty fast, so in 4 weeks. Compare this with the adults, where 1 milligram per kilo per day for 16 weeks is the definition for steroid resistance, and the cytotoxic, the cyclosporine and some other drugs that we will discuss in the other etiologies would be of use in patients who are steroid resistant. And in the history and your investigations, can you predict who are the people who are likely to give you trouble with and not respond to steroids? These are patients who have heavier proteinuria. So compared somebody has 10 grams of protein leak versus somebody who has 2 grams of protein leak, the 10 gram guy is likely to be more steroid resistant. So heavier the proteinuria, more the chances that it will be steroid resistant. If there is hypertension associated with the proteinuria, then the chances are steroid resistance is likely to be more common. If there is low GFR at presentation, which will be, even if you don't measure the GFR, if the creatinine is high, then likelihood that this is steroid resistant. If there is non-selective proteinuria, as we've discussed, there are some studies which show that if minimal change is associated with high serum IgE levels, they are steroid resistant. Then deletion in the 13q chromosome is another marker for steroid resistance. Then steroid gene has been studied, and steroid receptor gene polymorphism is associated with steroid resistance. And in the kidney biopsy, it's important to note it's not the glomerular histology as much as the tubulointerstitial space which is going to tell you whether there is steroid resistance or not. So if there is a lot of tubular atrophy, there is a lot of tubular fibrosis, chances are that this patient is not going to respond to steroid. So the best thing for all these patients is, if there is very heavy proteinuria in non-minimal diseases, best to combine them with cytotoxic therapy to begin with. The other concern of late is that steroid resistance seems to be increasing, and this is because non-minimal histology is becoming commoner in the last 2 decades, and this is blamed to the fact that there is a more prevalence of focal segmental glomerulosclerosis, the what is called as FSGS, and this is because of the widespread obesity that is coming up with the modern lifestyle. So steroid resistance is a side effect of the modern lifestyle, just as diabetes, hypertension, and the syndrome X that we are facing nowadays. So steroid resistance is indeed going up, and the reason for that is that the focal segmental sclerosis is going up. And you must remember that there are obesity is listed as a cause of FSGS. Then HIV is a cause of FSGS. Heroin abuse is a cause of FSGS. So there are a lot of secondary causes of FSGS. So if you have a FSGS on your histology, you must look for secondary causes. And this is what I told you, obesity epidemic. It's not just the USA, but now in the metros in the country also, is the lifestyle is leading to obesity and more FSGS. If there are any questions on minimal change, it would be pertinent to have them now, but otherwise we move to the...
Yeah, only minimal change I want to ask. You told that though it is the renal pathology is less in comparison, but it is prone to relapses.
That's the
why relapse?
Well, as I told you, there are a lot of studies, and till date at least one factor has not been blamed on the relapses. Why it relapses is not the... Once that answer is there, probably there will be a drug which will prevent the relapses, and then minimal change will be a one-time disease like any, say, sore throat or pneumonitis, and you can treat it and that's it.
But to decrease the relapses, we can keep a longer maintenance dose.
That's right. Most studies point that you must give a longer period of steroids. You should combine cytotoxic, cyclosporine. Now mycophenolate has come up, which is also a newer immunosuppressive agent. We will discuss that in the subsequent histology.
I think we can go to the next year.
That's right. The next...
to
yes.
prevent the side effects of steroids, we give pulse therapy.
Yeah, pulse therapy gives one-time high-dose steroid instead of exposing the patient to low doses for a long time. So this is believed to induce remission faster, and after pulse, generally the recommendation is to give half the oral dose than normal what is recommended. So in adults, if we pulse them for remission, if we are able to induce remission with pulses, we give them generally 3 to 5 pulses. Then what you do is you put them on 0.5 milligram per kg per day instead of 1 milligram per kg per day.
Okay.
Okay, we
The
can
next
go to the next one.
histology
Yeah.
is the focal sclerosis, and this is the same glomerulus. Appreciate this, that this one segment of the glomerulus is totally sclerosed. Here you can see patent loops, and these are all variants of focal segmental glomulosclerosis. Here you can see the tip of the glomerulus, which is showing the, can you show the slide? Yes. The tip of the glomerulus, which is showing the fibrosis. This is what is classically seen in HIV, called the collapsing. You can see that the Bowman space is now bigger than this glomerulus seems to be collapsing, and all these show segmental fibrosis instead of the whole glomerulus being fibrosed as you would see in sclerosing glomerulonephritis. So this is what is classically the histology of focal segmental glomulosclerosis. Focal segmental glomulosclerosis essentially presents as heavy proteinuria. There is derangement of renal functions at onset. These are patients who have fairly severe edema, they have very significant hypoalbuminemia, and their creatinines at presentation are generally high. And these are candidates for more severe immunosuppressive regimens than what you would offer to minimal change disease, because of the simple fact that glomerular injury here is more advanced, there is already sclerosis, and to control the damage you have to induce with remission with very high immunosuppressive agents. So what are the immunosuppressive agents that one would have in a patient who has focal sclerosis? Steroids, whether oral or pulse, as we've just discussed. Pulse may be a better alternative for patients who have very heavy proteinuria and FSGS. Then the second line again is the alkylating agents, whether you use them oral or IV cyclophosphamide or chlorambucil. The next line is the calcineurin inhibitors. Cyclosporine we've discussed. Tacrolimus is another CNI which is available now in the Indian market. It's more powerful than cyclosporine and has been used in some studies to treat focal segmental glomulosclerosis. And as I said earlier, you have newer agents coming up. Mycophenolate mofetil. This is a drug which is now being increasingly used in kidney transplant patients as a immunosuppressive agent, and so also the immunophilin modulators. The classical one is what is called rapamycin, and this is also another drug which is essentially being used in the transplant patients, but the pathology probably dictates the same use because of the fact that in transplants you are using them to immunosuppress the patient. Similar reason for using them in nephrotic syndrome. So if you have a patient with focal sclerosis, this slide sums up large number of studies, but the message here is note the green bars in this slide. And what it shows is that if you use steroids for longer periods to about 6 to 12 months, then you are likely to induce more remission versus if you are using steroids for 2 to 3 months. So what it sums up is that you must use steroids for longer periods in patients who have focal segmental sclerosis. What about combining alkylating agents with steroids in FSGS? The current consensus seems to be that alkylating agents probably do not add too much benefit to what you will get with steroids alone. So these may not be the best drugs for focal segmental glomulosclerosis. Compare this with what you have if you use cyclosporine, then you are likely to induce more remissions. So if you have high proteinuria, if you have higher serum creatinine, if the histology shows interstitial fibrosis, or if the histology shows collapsing focal segmental sclerosis, and if you are not able to induce remission of proteinuria, your patients are not likely to do well, and these patients are likely to go into renal failure. I'll skip a couple of slides and focus on some of the newer immunosuppressive agents, because that is essential for us to know. Mycophenolate has been used in some studies and has shown fairly good results. And this slide just tells you that if you are able to induce remission over a period of time, you are less likely to develop renal failure compared to if you are not able to induce remission. So it's important to realize that remission is a marker for good outcome versus no remission, which is a marker for poor outcome. People have used therapeutic apheresis and vincristine and a host of other therapies for focal sclerosis. This is the last entity I would like to discuss, and this is, here you look at the right lower corner. This glomerulus shows you that the basement membrane is much thicker compared to what you had in minimal change disease, although the cellularity is not up. And this is the classical membranous glomerulonephritis. Most of them will present as nephrotic syndrome. Some would be asymptomatic proteinuria. Some of them would have renal insufficiency to start with, hypertension. Renal vein thrombosis is a common complication of membranous. Many of them would develop spontaneous remissions. So if you have membranous with mild proteinuria, it may be best not to treat these and watch them for a period of time. Many of them will go into spontaneous remissions. The risk factors are again heavy proteinuria and abnormal renal functions at presentation. If there is little proteinuria, then you can just treat them symptomatically, maintain a good blood pressure, use ACE inhibitors. But if there is heavy proteinuria, use steroids, and this is one disease where cytotoxics works better than cyclosporine. And so in patients who have a higher risk of developing renal failure in the form of heavy proteinuria and abnormal serum creatinine, it's best to treat them with steroids and cytotoxics or combine them with cyclosporine. Here I would like to remind you once again that when you are using steroids, you must know the side effects of steroids. So importantly, I'll sum up: growth retardation, acne, moon phases, emotional irritability, psychiatric disturbances, menstrual abnormalities in ladies, peptic ulcers, cataracts, osteoporosis, and avascular necrosis of the neck of the femur. These are side effects without which you should never put your pen to paper and write steroids.
Okay, thank you, Dr. Saxena. Because we are coming to the end of the session, we'll take up some of the discussion in the next session. I'll request the viewers, please be with us. We'll have a 15 minutes break now, and we'll be back at 4:30 p.m. and in the next session we'll continue wherever we have left. Please be with us.